Okay, thank you, Marcy. Now on to today's business. Our first session this morning will focus on the business dynamics for purchasers of health care. Leading the discussion will be David Cowing from our Health Innovation team. So welcome, David, and your panel.
Thank you, Mr. President. Today we're going to talk about California's changing marketplace from the perspective of purchasers. As Marcy stated, CalPERS is the second largest public purchaser employer in the nation with 1.5 million covered lives. This 1.5 million covered lives is more than 10 states in the U.S. We have more covered lives than Hawaii or New Hampshire. Also, CalPERS spends $9.2 billion in 2018 on healthcare. And so we live in exciting times in the healthcare world. Governor has put forth a vision of universal healthcare in California. And while I think everyone agrees on the goals of reduced costs and better quality care and better health, there are a number of different ways in which solutions to these problems. And so I'm excited today to have three great speakers here today to discuss this topic. We have Suzanne Del Banco, is going to talk about payment reform strategies. Suzanne is the executive director for the Catalyst for Payment Reform. She's the executive director for Catalyst for Payment Reform, an independent nonprofit corporation. She was the founding CEO of the Leapfrog Group, and she holds a PhD in public policy from the Goldman School of Public Health and an MPH from the School of Public Health at the University of California, Berkeley. We have David Lansky, who's going to talk to us about using purchaser leverage. Dr. Lansky is a senior advisor and former CEO of the Pacific Business Group on Health. He is now a senior advisor, and he continues to lead PBGH work in advancing outcomes-based quality measures for healthcare. He has served on a board member advisor for numerous healthcare programs, and he also holds a PhD from University of California, Berkeley. Wow. And then we have Bill Scott. He's an actuary from Mercer. He's a senior actuarial consultant at Mercer's Los Angeles Health and Benefits practice. He has over 30 years' experience in group benefits marketplace. And Bill is a fellow of the Society of Actuaries and a member of the American Academy of Actuaries. He is also a graduate of Brown University and has a degree in economics and something dear to my heart, applied mathematics. So with that, let's move into our presentations for the day. Suzanne.
Thank you, David, and thank you so much for the opportunity to be here today with you. It's really an honor. When I think about where I look to for leadership in healthcare, honestly, CalPERS comes very much to mind. And while I hope I can help educate and bring some information to you today, I think it's a mutually beneficial relationship as far as I'm concerned. So I'll start by telling you a little bit about where I'm coming from, my perspective and the organization I work with, and then I'll dive into what we see today as being potentially effective value-oriented payment strategies in healthcare. So David mentioned a little bit about Catalyst for Payment Reform. I'll just provide a tad bit more information. Catalyst for Payment Reform, otherwise known as CPR, has been around 9 years now. It's an independent national nonprofit organization, a 501c3 educational organization. And our goal is to provide thought leadership to and coordination among employers and other big healthcare purchasers like CalPERS who share the common goal of wanting to get better value for healthcare spending. And by value, we mean better quality, more efficient care, more affordable care. And as our name suggests, we obviously believe that changing how we pay doctors and hospitals creating stronger incentives for them to improve quality, to improve efficiency, and to reduce waste has got to be at the heart of our strategies. But as you'll hear me describe, as soon as you try to pursue better value in healthcare, you can't just limit it to the incentives you create for doctors, for hospitals, and other caregivers. As CalPERS has experimented with, and many others are now too, we have to align the incentives all the way across the system, from providers to payers to patients. And so we look not just at payment reform strategies, but also at the benefit designs that we put into place in the health insurance offerings, as well as what healthcare providers patients have access to, or the kinds of incentives that they have to use certain providers. If you look at our membership, it's pretty diverse. We started out really focused on large private employers, household name companies. But as word got out about Catalyst for Payment Reform, an increasing number of state Medicaid, employee, and retiree agencies have joined our group. We have some union trust funds, we've got some universities, we have a nonprofit. We actually have an employer with 300 lives. So it's quite a diverse group, but really what brings them together is the desire to try to crack this nut and be innovative and try to find ways to address rising healthcare costs and the fact that we really don't get a reliably high value product from the healthcare system. So with that, I'll get into the topic for today, which is talking about payment reform and other high value strategies. So let me just take a minute to talk about what I mean by payment reform, and also invite the board, if anyone has questions throughout my presentation, please feel free to raise your hand and interrupt me, because I want to make sure that everyone is feeling like they understand the topics I'm discussing, and I'm going to try to minimize my use of acronyms and the alphabet soup we have in healthcare, because even for people in healthcare it can be alienating. So when it comes to payment reform, what we mean by that is a range of healthcare payment methods that we use in paying doctors and hospitals and other caregivers that promote or leverage greater value for patients primarily, but also for those who are paying for their care, the purchasers, and payers, as well as healthcare providers. If we come up with reforms that don't feel sustainable to all parties, they won't succeed and they won't last. So we need to find ways to change how we're paying for care that's sustainable, but ultimately gets us more of what we're looking for from the healthcare system. And historically, as you probably are familiar, the way that we've paid for healthcare in this country is what we call fee for service, where we pay a separate amount for every item of care that's delivered, whether it's an office visit or a laboratory test or a drug that's dispensed. And when you pay a la carte for everything in healthcare, it creates an incentive for healthcare providers to deliver more care and more expensive care, because they can generate more revenue by doing that. So while it's good to pay in that method, especially in areas where you're worried that care might be underserved, or that there might be an undersupply of care, like let's say mental health, where we don't have enough providers today. In other areas, we deliver too much care, and in some cases not appropriate care, and the way that we've been paying historically has not done us any favors. So the challenge is to try to think about how to add the right incentives so that we don't have these perverse incentives for too much care to be delivered, but we create incentives for the right care and the right amount of care to be delivered in the right place at the right time. So that's really what payment reform is about. And when Catalyst for Payment Reform got started in July of 2010, we did an unofficial query of some of the nation's largest healthcare payers and asked them, out of all the dollars they're spending on healthcare services, what portion were tied to performance in some way? What kind of incentives were they using? And they said at that time that just between 1 and 3 cents on every dollar, was creating some kind of incentive. For the most part, 97% of what was being paid created no special incentives for better quality, more efficiency, more affordable care. And so we've been tracking it now since 2010, and here we are today in 2019, almost 2020, and we estimate that we're somewhere between 50 and 60% of every dollar now has some kind of incentive tied to it for healthcare providers to do the right thing. The challenge is that most of the new payment methods that are out there have just added new incentives on top of the old perverse incentives of fee-for-service. So we continue to pay on an a la carte basis, And then we add on top of that some extra incentives if providers meet certain quality standards or they meet certain target budgets or things like that. So we're incrementally changing how we pay for healthcare. And there's value in that, because if you try to completely overhaul, we may never get there. So, the incremental approach has some logic to it, but we're not quite at the place yet where we can declare victory, that these new methods of payment are making the difference that we need. So let me talk in a little bit more detail. I know the panel after this one will talk about accountable care organizations, so I don't want to sort of scoop what that panel is going to talk about. But let me just describe this as an example briefly. So one of the major types of reform that we're seeing in healthcare, and CalPERS has been working with, is this idea of bringing large groups of providers together, of different sorts of providers that together could care for all the needs of a certain population. And if we give that group of providers a target budget for what we think that they should be able to spend to take care of this population, and give them some incentive to beat that budget, spend a little bit less than they get to keep the savings, can we create a more affordable, higher value healthcare system, especially if they're held to account for certain quality standards and meeting those standards? The results have been mixed so far. First, the Medicare experimented with this, and slowly but surely we've seen Medicaid agencies at the state level, and then also private payers experimenting with this. And while we don't have as much transparency into results as we would like in the commercial market, because they're often afraid to share results, so far I think we can say that we don't know yet if this approach is a slam dunk. As another example, another approach to trying to change the way we pay for healthcare is this idea of, think of it like a package price. You're planning a vacation, and rather than paying for your airfare and your hotel and your rental car and all that separately, sometimes you go on a travel website and they say if you buy it all together now, you'll save 20 to 30%. So the same idea is being tried in healthcare in small ways, and we typically call it bundled payment or episode-based payment. So let's say someone needs a hip replacement, or they have the need for spine surgery or something like that. Rather than paying for each piece of their care separately, a la carte, like we've been doing in the past, we agree on a set price for all the services that patient is likely to need. And then we hope that will create some incentives for providers to work more closely together and coordinate their care better for the patient, because if they happen to spend less on that patient than what the bundled payment amount is, then they get to keep some of those savings. So it's kind of a similar incentive to what I was describing before. I would say that the results here, again, are somewhat mixed, but we're seeing that there is some promise, that some of the early results have been very effective. For example, in the area of maternity care, and David Lansky could speak to this example in a moment if you'd like. In bundled payment for maternity care, there's been some evidence that we can reduce the proportion of births that are delivered through cesarean delivery unnecessarily. Because it costs more for providers to do the cesarean delivery, and if they're getting paid a set amount, they have some incentives to be more careful stewards of the resources. So long story short, there's been sweeping changes to how we pay for healthcare over the last 9 years. But we can't yet say for sure that we have been successful at getting better value as a result. We also know that there's no one-size-fits-all solution, that we can't say, oh, if we just paid for everything with bundled payment, we would be better off, because there are some providers that aren't going to be able to handle those payments, or there are some types of care for which it's not an appropriate payment method. So it's complicated, and there's lots of different methods being used, and we have mixed results for all of them. But I think the important takeaway is that we have to keep experimenting, and we have to keep trying, because until we get the incentives right, we're not going to get exactly what we want to pay for from the healthcare system. The other thing I would say is, with experimentation, we need evaluation, and we need greater transparency. And one of the things that Catalyst for Payment Reform and other large purchasers have really been pushing for is for the commercial payers to be more transparent about the results of their experiments, so that we can all learn from them and figure out what we need to tweak and change, and so we can keep evolving and trying to get to a place where we have effective payment methods. One example would be a CPR recently tried to create something equivalent to the nutrition label. You know, when you go into the grocery store and you look at a soup can, you know where to look for the calories and the fat and the sodium because it's a standard template. Often what we find in healthcare is that everybody measures things slightly different ways, and they report information in slightly different ways, so it becomes very difficult as a consumer of that information, whether it's an employer or a patient, to be able to compare apples to apples. Very difficult. So we're pushing the industry to accept a standard for how it reports on accountable care organizations, again, inspired by the nutrition label. And we're slowly but surely having some success there. And the reason that's important, again, is so that we can learn whether these new approaches are working and figure out what elements of them might be important to scale that success more broadly. So we've talked a bunch about how we pay for healthcare and the fact that we've been trying to change the incentives inherent in how we pay. The other thing that I need to mention, though, are prices. And I think this is something that CalPERS is very familiar with because of really the groundbreaking work that CalPERS has done with reference pricing. But prices increasingly matter in healthcare because as we look across the country and the consolidation that has been occurring among healthcare providers, that consolidation has allowed them to gain more market power, which has allowed them to charge higher prices. And when we look at what's driving healthcare cost growth, prices are always one of the top reasons why healthcare costs are growing. So at the same time as we're looking at how we pay, we also need to look at how much we pay. And are there ways that we can address those prices as well as the method of payment? So this consolidation is likely to continue among healthcare providers, so it's not going to be a problem that goes away. The other sad news is that when prices go up, it doesn't mean that quality gets better. There's evidence about a mile high that prices go up, and there's almost no evidence that quality gets better when those prices go up. And unfortunately, with all the efforts that people have been making to change how we pay for healthcare, some of the savings we might generate through that could be dwarfed by prices getting higher. And so it's just been increasingly important to find ways to stimulate competition in the healthcare marketplace through things like reference pricing, which CalPERS has done, so that providers feel a sense of competition both on the quality front as well as on the price front. The other thing I'll say is that there is also some positive evidence that in addition to using payment reform as an approach, it's worthwhile experimenting with different ways of designing insurance benefits and the networks of providers that patients have access to and thinking about those in different ways. So, I think, 10 years ago, it was hard to find employers who were really experimenting with benefit design because people were very afraid of being abrasive and disruptive with their employee population. But I think everyone has gotten more comfortable with the idea now because we hear Americans crying out for how expensive healthcare has become, how unaffordable it is for their families, and that they're willing to make trade-offs now between having broad choice of providers and healthcare that's affordable. And so when it comes to benefit designs, there are examples, for example, Walmart using a Center of Excellence program for spine surgery that has an incentive with it to use the Center of Excellence because there's no cost sharing on the part of the patient, as compared to some cost sharing that they would have to have if they went to a surgeon that wasn't part of a Center of Excellence. And if the patient chooses to go to the Center of Excellence, they also get an evaluation up front to make sure that they're appropriate for that spine surgery, that it's really going to benefit them. And what Walmart found is by encouraging people to go to the Center of Excellence, 50% of those patients who'd been referred by surgeons at home found that they didn't actually need the surgery and that it wasn't going to be beneficial to them. And in fact, it would be better if they followed some other course of treatment like physical therapy. So it not only creates a better experience for the patient because they're not undergoing unnecessary surgery and the risk that comes with that, but they're more likely to experience better outcomes. And of course, CalPERS reference pricing program for total joint replacement, as you all probably know, reduced average price by about 26% and reduced selection of high-priced providers by 34%. So these kinds of incentives where patients have different amounts of cost sharing out of pocket can be effective at getting people to the right providers and more appropriate costs. There's also some evidence that if we create incentives for patients to use certain providers as part of their health insurance plan choice, that there also can be some savings. So for example, in Massachusetts, the Group Insurance Commission that buys for state employees and retirees experimented with a narrow network, and they found that those patients who enrolled in those narrow networks spent 36% less. So they were making a choice, those patients, to not have access to certain high-priced providers in Massachusetts, but by doing that, had a lot less spending out of their own pockets. They also experimented at the Group Insurance Commission with tiered networks where there's different amounts of cost sharing depending on which provider you go to. And if you want to go to a very expensive one, you have more cost sharing. And if you go to a less expensive one, there's less cost sharing. And there's some quality metrics that are mixed in with that as well. And the tiered networks in Massachusetts were successful at reducing the proportion of patients going to those poor performing providers. So those poor performing providers that were in the lowest tier experienced a 12% drop in their market share of patients coming from the Group Insurance Commission, which means that they were seeking care from higher value providers. Similarly, in Massachusetts, but in this case, not the Group Insurance Commission, but the Blue Cross Blue Shield of Massachusetts plan, their experiment with a tiered network reduced the total adjusted medical spending per member per quarter by 5%. So fairly significant in an era when healthcare costs continue to increase. How am I doing on time? 2 minutes, okay. So just to reiterate some of the things that I shared in terms of thinking ahead, and this is what David's then going to take from here is, what are our opportunities going forward? I think it's critical that we continue to demand transparency from the healthcare system. If I've shared anything with you, it's that we are trying in many different ways to help people get better value for their healthcare spending. But we still have a lot to learn, and if we don't have access to information about how these experiments are going, then we're not going to be able to learn as much as we need to. And we also need transparency for patients to be able to see differences in quality and price to the degree you want to implement benefit designs like reference pricing. So at every level, we really need transparency, and it really takes the constant pressure by purchasers like CalPERS for that to exist. We also need to continue looking at benefit designs as a possible part of the solution because as we experiment with these benefit designs, we're finding ways to connect patients with high-value providers, minimize their out-of-pocket spending, and send important signals to providers in the marketplace about what it is that patients are looking for, what it is that purchasers are looking for. And similarly, I would say the same thing about provider network design. By sending a signal to high-priced providers who are charging higher than competitive prices that we've noticed, and that there are opportunities for patients to have lower cost insurance options if they seek an insurance product that doesn't include those providers or that charges more for them. Then we keep the pressure on and try to help stimulate some competition among providers in the healthcare system where there is less and less of it. And then we got to continue experimenting with alternative payment methods, as I've shared. The last thing I'll say is that I think another exciting area is that where there has been little competition among providers because of consolidation, there are new entrants that we might not have imagined 10 years ago. The use of telehealth is still not maximized. The ability of patients to have primary care visits from their phone is something that is growing but still not fully tapped. More and more employers are using on-site or near-site clinics that they share with other employers as a way of really increasing access to primary care and controlling utilization of a very expensive healthcare system in the community. And even the use of retail clinics and urgent care. I had the opportunity to do a big literature review on both of those topics this last year, and the results are really good. I mean, they really do save money, and the care is quite high quality. So there's alternative sites of care that people can take greater advantage of in the future. So with that, I think I'll say that we have a lot more to learn, but we are slowly getting there.
We have a question. Ms. Taylor?
Sorry. Thank you. Thank you very much. This is a lot of information. It's a lot of stuff that I think CalPERS looks into all the time. I guess my question is, how are you as you're looking into this and researching these methods, how are you doing the research? Are you asking folks? Are you providers versus carriers? How does that work?
It's a great question. So we, on a regular basis, review the peer-reviewed literature, published articles that are showing results where the studies are done in a more rigorous way. So that's one source of information. But as I mentioned, unfortunately, in the commercial market, it's really hard to get people to publish those results. And so we at CPR conduct health plan user groups, which are meetings that we establish the agenda for with a handful of the largest health plans in the country and some in California, where we ask them to report results to us on a regular basis through a quantitative scorecard that we keep, as well as real-time meetings that we have with each other. So that's another source of information that we have. And then we also learn from our employer and other purchaser members about the experiences they're having, in some cases with programs that they've established themselves through direct contracts and things like that. So there's multiple sources, and I wish we had a national database of really solid information we could all turn to. It's not quite there.
That would be awesome if we could get that kind of cooperation. Maybe it would help us solve this problem. I was wondering if the confidentiality behind the information that we would like. So for example, I'm aware that we can, an insurance carrier can go to a provider to pay for me for whatever, say, a knee surgery. And then a different insurance carrier goes to a different provider for someone else. They're not the same price, but we can't find that out. So how do we mitigate that to try to get these effective strategies working? Is that a regulatory issue? I'm just curious.
Yeah, I mean, this is a topic we could talk about for hours. So, price is a really challenging area. So there are ways at getting information about how much one is spending at different providers. Employers and other purchasers use data warehouses where they pool data and try to get enough of a sample size, if you will, to get a handle on how much they're spending for certain types of care by different providers. It may not be the price, but they can at least see the total cost of care for something because of claims. There are increasingly price transparency tools that health plans create for patients, which really are geared more towards showing them what their out-of-pocket costs are going to be, but sometimes there's ways of sort of backing into it to figure out what the price is. There was actually a recent study done by RAND that pooled data from self-insured employers, and in some cases all-payer claims databases that were able to participate, and some health plans to try to infer what prices were being paid to hospitals across 25 states. That study just came out on May 9th, I think it was. Oh, yeah. And there's going to be another iteration of that study as more purchasers participate in it. So there's been many different types of approaches already to reveal price. There's a lot of debate as to whether price is a trade secret. Should it be, is it okay for it to be held privately, or is it, a public good? And different states are approaching this with laws and regulations in different ways. We actually just created with UC Hastings a database of state laws addressing price transparency as one of the 5 topics we've covered in this database. So we're going to be coming out with a report on the latest, probably in the I'll say by the end of the year. So it's too much to go into here, but there's a lot of different approaches, from trying to, force the revelation of prices to just requiring that providers and payers answer questions of patients about the price within a 24-hour period or things like that.
Well, I appreciate that. And I appreciate this report. It is difficult to combat the issue of our rates if we don't get a look into the pricing. So thank you.
Mr. Rubalcaba.
Thank you, Mr. President. Thank you for the presentation. I was intrigued by their study of the network designs in Massachusetts, and one of your findings was that when you have tiered a value network and then the relative network, that people, of course, I'm assuming the healthy people and the people who were cost conscious went to the more value network, and that's what that reduced market share from the full network. But I'm always intrigued by people that get left in the other full network, either because they live in a neighborhood where they have the old plants, and so, or they somehow believe that they need higher value, higher, I don't know, have a higher acuity, and so they stay there for whatever reason, maybe a perception. But the rates will go up for those people. So how do you adjust that when you have various population, and yet it could be the same insurance carrier, but it's two networks? So how do you address that?
It's a fantastic question, and I don't have an easy answer for you, but I would say that we can't make blanket statements about these strategies being a good idea everywhere. You have to look at the specific market dynamics of any particular market and try to model these things out to figure out if, on balance, is it going to make healthcare more affordable, for the purchaser who's paying for it, as well as for the patients. And so I think you raise a really important issue, but there's no one answer to the question. And if there are health economists in the room, they may want to take a stab at it too. But I just think it has to be modeled out for the specific market and the specific circumstance. I think there are going to be some markets in which a narrow network or a tiered network isn't really viable or a good idea. But in markets where there's adequate competition among providers and enough access, it could work, to the advantage of the purchaser and the patient.
Is there any, I don't know what the situation was in Massachusetts, but is there any, everything's money. So is there any way of, any incentive to try to move money to the non-effective providers to try to upgrade them, or maybe tell them we'll buy you out and just, I don't know, I'm just wondering, how do you incentivize high-performing providers to excel and the not-so-performing providers to
it's a great question.
Because sometimes it's just marketing. Sometimes there could be a provider has a lot of marketing billboards and they attract certain people, even though their quality outcomes are not that, compared to other people, are not that high given the price.
Yeah, I mean, you've made a lot of really important insights into what's true in the healthcare system, all in that one question. I think for the most part, where people start from is, how do I connect the patient with the high-value provider? That's the first step, so that you're rewarding the high-value provider with more volume. That's not always a reward if a provider's at capacity, but if they're not, then it's a reward. And how do you make that poor-performing provider want to get better? So that's sort of step number one. Step number two is, does that poor-performing provider have adequate capital or training to become better? And if they don't, you can't just magically assume it's going to happen by taking patients away from them. And so I think that this is a big challenge. And if you talk to the different commercial carriers, the health plans, they have different philosophies about this. Some of them will enter into a contract with a poor performing provider that they would call an accountable care contract, even though that provider doesn't look anything like what we would hope an accountable care organization would look like, because they're not good yet at coordinating care or assuring continuity of care and managing complex cases. There's a lot of things they need to learn. But by giving them a contract with quality improvement incentives and the opportunity to share in savings, the hope is that they will get better. Other commercial payers would look at that provider and say, I would never enter into a contract with them like that because it misrepresents what an accountable care organization is. So there's so many different approaches being taken to try to find ways to inject capital into these poor performing providers to help them improve. And in other cases, that's not the focus, and the focus is really on the high performing providers. So it varies. But it's a big and tricky question that I don't think I can adequately answer right now.
Thank you.
Yeah.
Mr. Miller?
Yeah, my question, I think you answered it substantially with Mr. Rubalcava's question, but I had a couple questions there. But the one thing that really strikes me is a big part of what we, or I should say I, the royal we, grapple with is we've got so many distinctions, you know, acuity, demographics, age, rural, urban, generational equity issues, that outside of the context of, you know, a future single payer type context, we always have to try to figure out how are we going to balance the marginal or modest benefits to the majority versus the disparate impact on the particular segment, whether it be high acuity, specialty care needs, or rural, whatever. And that's a real challenge for us because this whole model tends to be driven by this imperative of cost to the employers. And the finer you slice and dice your member or patient population, the bigger the disparate impact on the folks who are kind of left out of that picture. And I think that's going to continue to be the challenge we have, or unless we get to kind of a single payer where you don't have that, you know, playing one piece against the other. The other thing that I think I grapple with a lot is quality means something different to everyone. And when we think about quality in terms of you know, quality of care measures or HCAHPS or any of those type of measures versus the patient experience, which can be very far removed from their perception of quality of the actual clinical care from a practitioner standpoint. And that drives a lot of the behavior and decision making as well as just the dollars, but doesn't necessarily drive quality outcomes. You know, getting around in the beautiful Jaguar may not be any different functionally than getting around in the Chevrolet, but it may cost you a lot more and be not as dependable. But from a patient experience standpoint, they'd rather be in a Jaguar. So it's pretty challenging, and I'm wondering, you know, how in your studies do those kind of more kind of consumer behavior economics kind of considerations come into it?
Yeah, I mean, you know, we're not a primary research organization, just to clarify. We digest research that other people do. But I will say that our members are increasingly interested in patient experience of care and patient-reported outcomes as a means of assessing quality. And I don't mean patient satisfaction, not, you know, how nice was the waiting room or that stuff, but things about clinical quality that only a patient can measure. When we were creating this nutrition label for accountable care organizations, we had discussions with every major carrier in the country about their ACOs and their results, their accountable care organizations. And only one of them, I think at that time, was even measuring patient experience. So we might take it as a given, but it's still not. And even though we can agree it's different from outcomes measures, clinical outcomes, it's something that is very relatable to patients, and if it's done right, really can describe for us what the quality of care is to a certain degree. So it's something that we'll continue to emphasize. I don't think I'm addressing all the comments that you made, and I'm sensitive to the time for the other panelists, but I'd be happy to talk more after about it. But I think it's an area that we want to see getting greater emphasis.
Ms. Middleton?
Okay, thank you. One very specific question and then a general one. I was very intrigued by the Walmart experience with their centers of excellence. Was there any evidence uncovered there that opioid addiction was less in the population that went through those centers of excellence, surgical centers?
I don't think that they looked at that, and if they did, it wasn't something that was shared. So we performed the case study ourselves, and we wrote it ourselves, and it didn't come up.
All right, thank you. Following up on Mr. Miller's questions, patient experience, patients' belief that they are receiving the best quality care that they can receive, I think actually does contribute to better outcomes. If you walk into your doctor's office and think you're having an argument and a fight with the insurance company from the moment you make that appointment, you're not arriving thinking about your health care and what. So how are you going about examining patient experiences and the contribution that that has to better outcomes?
Yeah, and again, we're not a primary research organization, so we're not looking at that directly. What we're doing instead is pressuring the health insurance companies to include measures of patient experience and to look at that as it relates to the overall performance of their accountable care strategies or other strategies that they're putting into place.
Okay, Ms. Yee.
Thank you, Suzanne, for the presentation. I think if there's any takeaway, it's the even though you're not a primary researcher, there's a lot of data out there, and just what does it mean, when we actually are trying to get to the right design with respect to healthcare. I didn't hear you mention that. I was intrigued by this focus on innovative benefit designs, where it's really the consumer looking at that intersection of high quality, low cost, and how would you characterize, I guess, high deductible plans, where if there's an effect with respect to consumers actually self-selecting out of seeking care?
Yeah, I mean, again, I haven't done primary research on this. I'm digesting the literature that's out there like everybody else, and I think what we have seen is that high deductible plans across the board mean that patients tend to refrain from seeking care. Sometimes that's good because they're not getting care that they didn't necessarily need, but sometimes it's bad because they're not getting the care that they do need. And it's sort of a blunt instrument to do a high deductible plan, and especially for patients with chronic conditions who need to be getting regular care, it can provide a bad disincentive from seeking that care. So I think there's been evolving thinking about how to pair high deductible plans with value-based insurance design, and there's been pressure to change regulations so that there can be more first dollar coverage for the secondary preventive services that someone with diabetes or asthma might need. And I think that's going to be critical. We're already seeing our members peeling back from using high deductible plans as much as they did, or keeping them but offering alongside another option that might be a narrow network that has a similarly low premium but more upfront coverage for these types of services.
Yeah, my question goes to the strategies of the future. Several years ago, I observed an experiment where they were talking about it was going to be predicated on driverless cars, a remote, being able to send cars to different locations. And they were talking about equipping minivans with certain kinds of equipment that, like blood pressure equipment, and also a screen that the doctor can communicate with the patient. And this was very interesting for our rural patients and those that are less mobile. Are you aware of that? And has there been any update on that innovative strategy?
Yeah, for reasons not related to my work, I just did a little bit of a deep dive into what they call wearables, things that you can wear on your body that then upload data remotely to healthcare providers. And we're at the point now where the van may or may not be relevant, because Apple Watches and other smart watches, if you want to call them that, are being equipped with software, and there are devices that can be attached to them that can communicate an incredible amount of information to healthcare providers. And I think we're likely to see in the next 5-15 years a real revolution in the kinds of tracking we do of patients, not just people in rural areas, but even on a daily basis, all of us, monitoring our hearts and everything else in ways that could be misleading and also could be very revealing of conditions that perhaps we don't know we have and that we need to seek care for. So, I'm not an expert on the subject, but I did just get some updates from people at UCSF who are doing a lot of research on this, and it's really incredible where it's going.
Okay.
Is this on now?
Nope, you gotta leave it out.
There you go.
I think now it's on. Yeah, thank you. Good morning, everyone. Thank you for the invitation to be here. I'm David Lansky, representing the Pacific Business Group on Health, of which CalPERS is a longtime member. And as Suzanne said, you may not appreciate it, but nationally you are regarded as leaders in thinking about healthcare strategy and executing it. So we all appreciate the leadership you've shown, and hopefully you'll continue to show. And I appreciate this last conversation is starting from the high-level principles and getting down to a very hopeful set of ideas for the future. I'm going to drag us back into the cold reality of where a lot of the purchasers of healthcare are today and what they're thinking about. I guess I need to prompt myself forward. That's me. So I start the title of this session. I wanted to insert one word because I really wanted to make sure there was one anchor point for what I talked to you about today. And the word is on this slide, and the word is leverage. I want to, in the couple examples I give you, building on Suzanne's, I want to talk about the opportunity you have not only to wield your own leverage in the market with the purchasing power and the number of lives that you influence, but also to be in alliance with others who share your values and goals to have even more impact on the market. In a state of 40 million plus or minus people, even with as large a block of lives as you have, but as scattered as they are across the state, it's hard for you to influence the behavior of hospitals, doctors, technology companies, health plans, and all the other drug companies, all the other players who you would like to have listened to the direction that you're providing with the signaling you do. But in reality, they have many masters, and you are only one, and a relatively modest one to any individual hospital or doctor or drug company. So the question is, how do we collectively, who are representing the health, the well-being, and the pocketbooks of thousands and millions of people, have more influence over the decisions that get made in delivering care, organizing care, paying for care? So the group I represent, and the reason you're probably wondering, what is this a photograph of? It doesn't look like California. It's actually a picture of downtown Seattle, and I want to come around to why I want to give you Seattle as a case study in leverage, both a positive case study and maybe a cautionary case study. But there are lessons to be learned as we think about how to exercise more leverage in the healthcare marketplace. So Pacific Business Group on Health has been around for 30 plus years. CalPERS has been a very long time member. You see on here, similar to Suzanne's list, a lot of big national companies. The state of Washington, speaking of Seattle, is one of our members, both their public employee program like yours and their Medicaid program. And you see big companies like Comcast and Walmart on here. So these companies all share your concern about getting better value for their employees in the healthcare marketplace. And they are trying a lot of things. And what PBGH tries to do with them and for them is have them act in concert to wield their influence in the marketplace and in the policy community so that the policies and behaviors we get in the community are what we want, because we're speaking with one voice wherever that's possible. And I will give you some examples of that. One important context for this, which I know you're all sensitive to, is that everybody who sells healthcare services and products has consolidated. So you have a relatively small number of big drug companies, big pharmaceutical benefit managers, big health insurance companies, big hospital systems, big medical groups. We, those who purchase healthcare, are either individual people who are a tiny unit of one in the market facing these giant organizations, or at best we're employers with a few thousand or maybe a million lives working together. Whereas big companies like United Healthcare have 70 plus million lives, and they're huge organizations. The PBMs have hundreds of millions of people they're representing for purchasing drugs. We, as the other side of the negotiating table, are very small. So to get enough influence to balance that conversation at the bargaining table, we have to act in concert. We have less information because, as Suzanne described in the transparency comments, it's hard to get the data out of these other parties. If they don't want to give it to us, we can't really get it out of them. We have less information and we have less economic power than the people on the other side of the table, unless we act in concert. Just to remind you again of things you know painfully well, in the United States, we are spending roughly double the amount of money that people in other developed countries are spending for their health care. We're not getting better health care, we're just spending twice as much for it. So this is a problem that we have to grapple with directly. It is not 5 or 10% higher, it's double. We are spending an enormous amount of our national wealth and our state's wealth on services more so than anyone else in the world is doing. An actuarial company has estimated that right now in 2018, this was costing an average family of four $28,000 a year. And I just looked it up today. The average Walmart cashier makes $22,700. The average Amazon clerk makes $33,000. And we are spending $28,000 for health care. Essentially just as much as is going in their pocket is going in the pockets of the healthcare system. So this is an enormous impact on our economy, and from both public and private employers, it's a tremendous allocation of resources for uncertain value, as Suzanne has described. So we can't just let it keep going the way it's going. The idea that we'll just pay bills, maybe we'll get a 3% increase instead of a 4% increase next year and call that a win, isn't grappling with the severity of the problem. And this problem obviously compounds every year where medical costs exceed the cost of the economy as a whole. If you're the companies on the chart here, if you're Qualcomm or Disney, you are growing at the rate of the economy as a whole. If your healthcare spending is more than that rate, it's basically coming out of your employees' paychecks or your profits or your shareholders. So the imperative to figure out a solution is very strong for most of these organizations, I know for you. Now the good news is, and Suzanne's pointed to this, there is high-value care out there. You have found it in a number of projects you've done. Our other members have found it. Walmart's found it. We know it's there. In other words, it is possible to deliver high-quality care at an affordable price. The question is, why don't we get it? What do we have to do to generalize it, to make it common, so that every employee in every part of the state is getting high-quality care at an affordable price? And that's the leverage question that I think we have to really grapple with. And in fact, I think that's our job, if I can presume. The job of large purchasers, both individually and together, is to crack that nut, is to ensure that every person is getting high-quality care at an affordable price. The PBGH now has focused on three particular, this slide just mentions we have about 40 members. Together they spend about $100 billion and about 15 million covered lives. So potentially that's a lot of influence. Suzanne's organization has another large cluster of very powerful, influential organizations. So this is beginning to happen. We're beginning to come together in rooms like this to have these conversations. Question is, how do we focus and execute it? So there are three areas that our little nonprofit organization is focusing on, and these are themselves difficult and daunting, but just to give you a sense of where our priorities are for right now. And these priorities change over time as the market and opportunities seem to change. We are focusing a lot on primary care, and especially advanced primary care. And that means a number of things. Part of it means making sure we have high quality primary care being delivered. And it doesn't just mean doctors, to the last point. It could mean telemedicine, it could be nurse practitioners, it could be midwives, could be a lot of forms of primary care that are available to help people get their basic needs met without necessarily recourse to a specialist or a hospital. We're focusing on purchasing strategies, and Suzanne laid out for you a number of those, and I'll just give you an example or two to give you a flavor of how that feels in practice. And then thirdly, and this is our probably emerging area that I just mentioned, is addressing this consolidation of the marketplace, where the purchasers have less economic clout than the sellers. And how do we reconcile that? And I'll talk a little bit about that in a moment. But I think in all these areas, it's important to ask yourself the question of, what does competition mean? If we're not yet ready or not sure we want to have a single payer kind of administered environment where the government or some entity says, here's the price for that drug, here's the price for that doctor visit. If you want to have competition, what does that mean? And to the transparency point, can you have competition if you can't see the price? It's a senseless idea that we're going to have consumers or purchasers compete in the healthcare market and they don't know what things are going to cost until they get a surprise bill a month later. That's nuts. So we've got to stand up for competition if that's the model you want to advocate for right now, at least in the market. So think about competition as we look at all these examples. And also think about how much of this can we fix in the market with your purchasing power, your contracts, your health plans, and how much do you really need policy makers to influence? Because the market doesn't work by itself. So these are the three areas we work in. These are a bunch of services and programs we've operated at our organization, and you've been part of many of these through your staff and your programs. And I won't try by any means to go through all these. I just want to give you a couple of quick examples of how this works when purchasers collaborate to have leverage. And the first is the upper left-hand corner called Primary Care Transformation. And this is kind of a, arrogant idea, pretentious idea, presumptuous idea, that purchasers, Intel, Qualcomm, Comcast, should come in and tell hospitals and doctors what to do. You know, we think we're the cable company and we're going to tell you how to transform primary care. But I think Suzanne made an allusion to this. It's turned out that hoping that we change payment and everything gets better doesn't work. What we've learned is we have to actually get in there and help people do improvement work. Intel was actually the pioneer of this up in the Seattle area many years ago when they took a bunch of Intel engineers and sent them into doctors' offices and said, you know, the way you're organized is crazy. If you take an engineering workflow look at this, you can make it much more efficient and better for everybody. And they really showed people how to rethink the way they delivered medical care in a doctor's office. So we've taken essentially the same approach to primary care. We have a large grant from Medicare, from the federal government, to talk to 5,000 California primary care doctors and help them improve what they do. Minute to minute, day to day in their office, how they do diabetes care, how they do chronic care, how they tie mental health into primary care, so those are connected instead of separated. So we've been doing this now for about 3 or 4 years. We've saved about $200 million in Medicare spending because these doctors are more efficient in the way they practice. We've improved about 10% across the population in all the quality indicators. Their diabetes care is better, their hypertension care is better. And part of the way we do that is with data. Every month, every doctor sends us data on how they're doing with their diabetics and their hypertension, and we give them feedback on what they could be doing different and better, and it's a constant improvement cycle with 5,100 doctors in California. We also, by the way, tell the employers, if I'm Qualcomm or Costco, by the way, you had 752 patients getting care to these doctors last month, and their care got better. So there's a closed loop so that we don't tell them who those patients are, but we tell them that their own employees are actually getting better because of this model being in place. We've touched about 3.1 million Californians with that strategy. Now the reason that's a leverage play is because all of those companies you saw on the slide together are sponsoring that intervention. And they are together saying to the doctors, we want you to undertake these activities to get better. We, the buyers, are asking you, the sellers, to undertake this improvement work. It's a supply chain improvement strategy. So a second example I'll give you builds on the Walmart Centers of Excellence story. Walmart came to us, they're one of our members, about 6 years ago and said, we don't really want to run this just by ourselves. Frankly, we can't put enough patients into a Centers of Excellence network to keep it going. Can you go to your other members and bring in more people so that when we go to Johns Hopkins Hospital or Cedars-Sinai or wherever we go as a Center of Excellence, we'll say we're bringing more patients to you. We can negotiate a better price, we can guarantee you more service, you can make changes in what you do to take care of our population because we're bringing you enough people to make it worth your trouble. So we did that, and we built something called the Employers Centers of Excellence Network. It's at the bottom middle of that slide. And essentially we started with orthopedic surgery and spine surgery and bariatric surgery, and now we've added cancer this year. So that a patient like at Walmart or at Lowe's stores or at McKesson, these patients who need, let's say, a knee replacement, they can go to their regular care, just as they always would, and that'll be fine. Or they can choose to go into the Center of Excellence Network. They'll get on a plane, they'll fly to Johns Hopkins with a family member, they'll be put up in a Hyatt, they'll have their surgery there, and that has been negotiated as a bundled price. So to the payment point that Suzanne made, these are bundle prices. It's a fixed, predictable price for the care for a total knee replacement. And it's a consumer incentive if it's a value-based insurance design, where the patient is saying, yeah, I'll do that. And by doing that, they pay zero for anything. No co-pays, no cost sharing, nothing for the entire episode of care. So Johns Hopkins, in this example, is getting a patient at a fixed price. We are getting well-managed care, and the patient is getting free care at one of the best places in the world to get a knee replacement. And as a result, we have 0% people going to skilled nursing facilities after those surgeries. We have 0.5% complication rates, much better results, and patient satisfaction is through the roof. People love being treated in this concierge fashion. And for a Walmart clerk to be able to fly to Johns Hopkins to get this kind of care is just a superb benefit. Let me just jump to the functional markets question and the question of consolidation. We are going to be participating, you may know the Attorney General's filed a lawsuit against the Sutter Health System here in Northern California, and we'll be testifying in that suit about the effects of Sutter's anti-competitive practices on the marketplace. There are a number of this is a sort of a manifestation of a much broader pattern of consolidation and what that does to pricing in the marketplace. And Sutter in Northern California is a case where that has been really a serious problem, taking a lot of money out of the hands of working people and transferred it into this very large health system using practices which undermine competition. And that's something we feel we have to act again in concert to speak as employers about the effects of that on our populations. One attempt we're making in the Seattle area, and I'll close with this story, is to say to a number of employers, you know, if you work together, just as the providers are working together to create large consolidated enterprises like Sutter, you can work together to create a strong voice in the market. So in Seattle, it turns out that by taking the state public employees program, similar to CalPERS, by taking Amazon, Microsoft, and Costco, you've put together around a table like this 40% of the market. So with 40% of the market, basically everybody has to listen to you. And if that group comes together and says, here's what our contract is going to look like for next year. Here's what our risk sharing is going to be for next year. Here are the quality requirements for next year. Who wants to bid on that business? It's 40% of the market. Essentially, every healthcare provider has to come to that conversation. So it also puts the purchasers in the position of saying, here's what we want for our employees. Here are the quality requirements, and here are the cost expectations. The employees still have choice. This creates a menu where the employees can say there are now 7 essentially accountable care organizations in the Seattle market. I can go to any one of those 7 I wish. There's a dashboard of their costs and their quality scores, and I can choose any one of them, but they are all bidding on a common RFP, essentially, a common contract design, as a delivery system, with the health plan administering the claims for that. So that's the opportunity you have. I think in working, as in the case of the Seattle example, with other partners in the state of California, to say we are going to define the terms of competition in this community, what we're expecting people to do, and then giving people choices to access that with favorable benefit designs, that's an opportunity you have going forward. And I'm sure we'll talk about more examples coming up. Thanks.
Okay, and now we're headed to Bill to finish off this conversation about where the changing marketplace is headed.
Thank you, David, and thank you to the board for allowing me the opportunity to participate in this important discussion. Clicker.
We have a question. Mr. Jacobs.
Yes, thank you. Dr. Lansky, I was wondering if there are antitrust concerns with the approach that you just articulated for Seattle with everybody getting together.
As it turns out, the way to address that is they are not purchasing as a group. They are issuing a common RFP, and they're using a common contract template, which they can then negotiate individually however they want.
But it sounds like they're coming together to present a contract to the providers and then saying, this is the one we're going to use.
It's a contract template that they're going to use.
Okay.
And then Microsoft sits down privately with their counterparties and negotiates the final contract that works for them, for those parties.
It's a starting point.
Right.
Thank you again. Just a quick note about who Mercer is, my employer, in case some of you aren't familiar. Mercer provides a range of consulting, brokerage, and digital solutions to sponsors of employee benefit programs to help them create accessible, affordable, and quality employee benefit plans. These solutions address some of the multiple challenges and opportunities inherent in providing employee benefits, including controlling costs and risks, simplifying the delivery of benefits, and to create a competitive suite of benefits to attract and retain healthy and productive employees. Now, in pursuit of these goals, Mercer has developed a sponsor-driven healthcare transformation initiative. Our point of view here is that employers play a key role in the transformation of healthcare into a more rational and beneficial system that benefits the plan sponsors, such as CalPERS, because at the end of the day, it's the plan sponsors who bear the brunt of the cost. So certainly you should have a big voice in how benefits are delivered and how healthcare is delivered to individual members. As a starting point, we feel that action can be taken in these 4 what we call vitals for change, actionable steps that plan sponsors can take to drive change and improve outcomes and reduce costs. The first of these vitals is a drive to quality. And here we're talking about delivering the right care at the right time, at the right place, error-free, because more efficient care can reduce costs and improve outcomes. And the second of these vitals we're calling pay for value, and this is what Suzanne has been discussing as well as David. And here we're looking for ways to align reimbursement with value as opposed to volume, because you need the right incentives to kind of impact behavior change among the provider community. The next of these vital changes is to personalize the experience for the membership. And here we're leveraging data and technology to help employees make better healthcare decisions, because timely and relevant information is what is needed for employees to make better decisions. And finally, kind of an overarching theme of all of this is we want to embrace disruption by examining traditional and emerging opportunities with an open mind, because we need disruptive technologies and processes in order to challenge the status quo, which, as we're seeing, is pretty much unsustainable right now. And through all this, we've included this wavy line in the middle on data and analytics, because critical to the success of any program development is the use and management of data to help move the process forward. And in fact, at CalPERS, the data warehouse has become a key component as you develop your benefit strategies. So as we consider what all this means in terms of program design, I'd like to focus on the end users of the program. That would be the members who actually participate in the plan, and how personalizing this experience becomes relevant to them. Consumers are increasingly demanding a healthcare experience that matches the experience they find in other industries. Mercer's sister company, Oliver Wyman, recently conducted some consumer research related to healthcare, and there were 3 particularly interesting findings that came out of the research. First, we found that consumers are willing to pay more for convenience. The expectation of convenience is found in a lot of other spaces. You think of Amazon Prime and curbside pickup at Walmart and Target. They've become conditioned to expect personalized, on-demand services, and they're beginning to expect this from their healthcare experience as well. Second, consumers are willing to try retail clinics and remote visits for care, things like telemedicine. Individuals are becoming pretty comfortable with transactional and minor care done at alternative settings, as opposed to waiting 2 weeks for a doctor's appointment to become available, and then once you get to the doctor's office, waiting an additional 2 hours for the doctor to become available. This trend is likely to redefine what we mean by provider access. So no longer will provider access be measured by how many doctors and hospitals are within 5 miles of each of your members. Third, consumers are willing to share their personal health data. Not surprisingly, they've always been willing to share data with their doctors, but more and more they seem to be willing to share data with non-traditional groups, such as the wearable technology that Suzanne was talking about, and other healthcare apps. So, if employers and other plan sponsors flip the benefit design around and begin to consider the consumer first, things might start looking vastly different from the current unsustainable status quo. So on this graphic, we've summarized the traditional approach to plan design versus some alternative design philosophies that take the consumer into account a little bit more. With respect to plan design, The traditional approach looks at actuarial value and total cost of care as the key components of deciding what plans to offer to the employees and how many of them to offer. But these concepts are really kind of meaningless to the end user of healthcare. In fact, they probably don't even know what actuarial value means. In the reimagined design philosophy, we want to ask a couple of questions. Are consumers able to access their plans in an intuitive, simplified manner? Does it fit in the flow of their daily lives? If we can answer these questions yes, then we're going to find some more satisfied end users of healthcare, and attraction and retention will be enhanced. Next, the traditional approach to networks has been focused on broad networks and a high degree of access to providers among the membership, as well as soft steerage to network providers through benefit plan design differentials, such as an 80-60 coinsurance. But it's still a very complicated situation for members. They still are not sure where they should be seeking their care from. So the questions to ask in a reimagined design philosophy: what if you could personalize the steerage for each individual to the best provider, using data and analytics to find out, right, what does this individual really need? Where does he really need it? Let's get that person to the right place at the right time to take care of his condition. Next, we look at population health. The traditional approach is to set up programs to address high-cost conditions, but this really addresses only 1 to 5% of your covered population. For the other 95% of your membership, the plan is not really addressing their needs. The reimagined design philosophy focuses on each member individually, and the key here is you probably have 80% of your members who use very little care. The key is to keep them healthy, keep them from being getting conditions where they need more expensive and intensive care. And then finally, we look at affordability from the member's perspective. Typically, affordability is defined by the contribution that a member has to pay to participate in a plan. But more and more, this seems like there's no tie-in between the cost of participating in the plan and the value you get out of the plan. The reimagined design philosophy addresses social determinants of health. So for some people, the cost of healthcare is just so astronomical that it becomes almost of secondary importance when they're struggling to pay for food and housing. A more appropriate support mechanism for individual members will take this into account when constructing a contribution scenario. So, in today's healthcare environment, the user experience is so fragmented and confusing that people often disengage from healthcare just at a time when they need to increase their engagement. So what happens, they don't seek or don't get care, their conditions worsen, and suddenly they find themselves in a situation where they need extremely expensive care and treatment. So getting back to David's point about leverage, if employers and other plan sponsors can push healthcare transformation, the result can be a more logical, consumer-friendly marketplace. With that, and because I'm an actuary and can't help myself, I've also included some charts and tables that illustrate that some of the things that CalPERS is doing actually is reaping financial benefits. In the interest of time, I think I'm going to leave the study of this material as homework and turn things back to David Cowling to get further discussion underway.
Thank you, Bill. If you could advance the slides for me there. We have two questions that we would like to ask the panelists to start kind of a broad discussion about like where we're going in the future. So we talked about the California marketplace here, and when Suzanne talked about payment reform strategies, and CalPERS heavily involved in the past, at least historically in these. David talked about a lot of the, leveraging purchasing strategies as well. And Bill gave us some data around what we should look for possibly in directing our purchasing towards consumers. And so the first question I'd like to ask the panelists is, where should CalPERS be in 3 to 5 years on healthcare? And I'll start with Suzanne.
This is a tough question. I feel a lot of responsibility in trying to answer it. No pressure, but I think CalPERS needs to continue to be the leader that it is. Most employers and purchasers are pretty wimpy when it comes to experimenting and trying new things, especially in a tight labor market, because they're worried that they won't be able to attract and retain, the right talent. They're worried about the disruption. They don't have the bandwidth and the smarts and the sophistication that CalPERS does in understanding the healthcare system and understanding how to innovate in the healthcare system that we have. So to make a broad statement, I think CalPERS in 3 to 5 years should continue to be a leader in experimenting with what it's doing. What should it experiment with? If I think about payment reform, what we really haven't done much of at all, because we do primary research on the implementation of payment reform. That's one area that we do primary research on. And we do it actually for ourselves at the state level, as well as for the federal government behind the scenes for this national effort called the Healthcare Payment Learning and Action Network. So we gather data from health insurance companies across the country, and so we're well aware at the detailed level what kind of payment reforms have been put into place. What we have seen very little of are payment reforms that pose financial risk for healthcare providers. And risk sounds like a negative thing, but what we mean by that is payment methods in which we share the risk as the purchaser of healthcare with the provider. We're not trying to ask healthcare providers to become insurance companies where they have actuaries and can predict, how sick their population is going to be and therefore what they should charge, but at least the technical risk that they can be responsible for in terms of getting care right and coordinating care and making sure that they're adhering to clinical guidelines. We think that providers should be pushed over time in the right way to accept more financial risk for the patients that they're caring for. And this could be in the context of accountable care organizations, where instead of the accountable care organization only being subject to a shared savings payment arrangement, they also have potential downside where if they overspend the budget that's been set for them, they have to eat some of those costs. Likewise with bundled payment, the idea is that it does put some of the financial risk on the provider. So if you're giving them a set package price for a certain episode of care and they overspend, they have to eat some of those expenses. So when we see out of all the payments that are being made in this country in the commercial market and even in the Medicaid market, which we also track, it's really single digits where there's shared risk being taken by healthcare providers. So I would like to see more experimentation with that so we see if those stronger incentives do pan out in higher quality, more affordable care. Now, not every provider can accept that kind of financial risk, and we shouldn't foist it upon those that aren't able to handle it. But especially in California, where we have a lot of experience with it, I think there can be more. So I'll just keep it at that. There's lots more we could talk about, but I'll leave it there.
I share that feeling of a burden of speaking to this audience on these ideas. I think you have to embrace your leadership role and take that on and maybe even amplify it. To me, when you observe the healthcare system and how many years this takes to make progress in some of these areas we're talking about, there is so much, I'll call it foot dragging, by industry players who are not going to get an advantage. The shift of opportunity and economic power to the patient, the family, the purchaser, means it's coming out of someone else's pocket. That's just the way it's going to be. And that means there are a lot of parties who are going to feel negatively affected by a change which benefits patients and families financially. And that means that organizations like yours have to step up and be very strong and clear in your expectations and the steps you're willing to take to advocate for the population you serve. So tolerating foot dragging and mediocrity is something we just can't do. So I think there's a cheerleading role by being visible and public in the positions you take. There's a clarification role of saying, we know the kind of health care system we want to move toward, and we're going to take steps to get us there, and we're going to look for partners who can help us take those steps. And then there's an implementation role, which is to actually execute in a few areas. I think it's wise to pick very few areas to execute in, and I would probably look at a portfolio approach and say there are 3 or 4 things we care a lot about, and you have to make those decisions. The kinds of things we're paying attention to now. I think demonstrating that bundled payment can be effective in specific clinical areas is an important thing to do. One of the areas that there's a lot of agreement about is maternity care, and there's a very well-defined bundle for paying for maternity care. The insurance companies have been extremely unwilling to pursue it. It's in the interest, it helps transform care. It involves more midwifery and doulas and birth centers. It'll stimulate more compassionate and patient-centered care. It improves outcomes dramatically. Patients love it. But the insurance carriers have been unwilling to do it. So that's an example of picking one thing and saying, we're going to partner with others around the state, including the providers, to make that kind of thing happen. I think primary care is an important area. As I said, particularly right now, mental health integration in primary care is an important area where you could adjust your payment methodologies, even in fee-for-service, to drive improved primary care and mental health. So that's just a payment adjustment you could work with your carriers to do. But again, it would be a symbolic thing saying we're committed to primary care, we're committed to mental health integration, we're going to pay people to do the right things. And then thirdly, I would pursue your ACO strategy. I know you'll have a lot more discussion about that today. But I think our takeaway is ACOs can be an important vehicle, but to Suzanne's last point, you've got to increase the risk dynamics in that relationship so that they're really committed to changing what they do, not just getting paid differently. So I think amping up the ACO strategy, similar to what I described in Seattle, is worth considering.
I guess I would take the vision of, I mean, I spent a lot of time talking about the end users of the healthcare system, the actual consumers, your membership. And I think for as long as I've been working with CalPERS and the board and staff, it's clear that membership comes first. I mean, your members are far and away the most important reason why we're all here today. And I think in 3 to 5 years, we need to come up with a way that to ensure that our members know what they're doing. They know how to navigate the healthcare system. They have the information, the apps, the materials to make sure that they're getting the right treatment for the right conditions at the right place at the right time, error-free, like I said in my discussion. But we need to be careful not to just say, okay, here's an app for your phone, go do it. I have an app on my phone for my healthcare carrier, and I don't think I've ever used it. My kids, they use it all the time. So we have to be able to address that there are different social determinants of health that we need to consider when we talk about making the healthcare system a little easier for our membership to navigate.
Okay, and that wraps up our presentation. Mr. President, we're open to any questions that the board may have.
Yes, Mr. Miller.
Oh, thank you, panelists. This has been just a wonderful session. I really appreciate it. A couple things. One, I was interested, pleased to hear the mention of this whole thing with Sutter. I think if we look around the country, there's some real examples where those kind of dynamics in a regional environment, urban environment, typically have resulted in some really ugly situations for the providers and the consumers. And so my hometown of Pittsburgh, the situation at UPMC and Highmark, and it's just been hideous. So I hope we can avoid that kind of thing in California. But one of the things that I grapple with, and I'd see what your thoughts are, our relationship with our members and the people we serve, constituents, And it's a long-term relationship. There are a lot of stages of it. Some people come into us as young single people coming into public service. Then there's kind of a stage where perhaps they start a family. Then we get folks we serve who come in as dependents. And then eventually people are mid-career, later career, retire. Our retirees have very different needs and expectations. And we have to manage engagement with them and serving them through the all those stages of that long relationship of career and retirement and family. And we've got, second and third generation state and local employees whose parents were being served by CalPERS. But because of the current system, their lifetime relationship with the healthcare system at large is discontinuous. And the more we try to manage competition to provide choices, then we get those disparities for them at different stages, different groups, different needs. And just some of your thoughts on how do we manage that competition going forward to still be able to provide for that increasing expectation of a quality experience as their needs and desires change, and as the technologies for real-time biometrics become available. How do we keep up? This industry is just moving so fast.
Great question, and I won't answer it, sufficiently, but I'll just share my thought is that, what we think of as the right way to have a relationship with the healthcare system, you choose a primary care physician, you have a relationship with that physician for as long as that physician's in practice, then when they retire, you move on to the next one. I think that experience is increasingly rare and probably will be, given even as much as we're trying to transform primary care. I think the availability of primary care physicians per patient and the time they can make for those patients is just shrinking. And so, I'm not really in that technology native population. I'm too old for that, but I think that we're going to have to make up for it in a variety of ways, and maybe it's through data, the ability to create a continuous, understand a patient's continuous experience through data that hopefully one day could actually be shared, in the right setting at the right time, at the right place with the right provider. But my take on it is that we're going to have to, move on a little bit from this idea that we have a long-standing relationship with a single provider, and find ways to, sort of band-aid things together to simulate it if we can't have it in reality. And I'd be curious of David's reaction to that.
Yeah, it's a really provocative question. I'm a little bit in between, I think, the poles that Suzanne described. People value the personal relationship with a doctor. It's a very important part. When they get sick and they get older, it's a very important thing. And we don't yet have technology that displaces that. And we are all becoming more sensitive to the risks of depending on technology to mediate a lot of our life decisions. So I think for the foreseeable future, for the period of time we probably are practically worrying about, to me, the question is, who do you trust to help orchestrate all this complexity? Do they trust CalPERS? Do they trust Anthem? Do they trust Kaiser? Do they trust their doctor or their brother-in-law? Or who is it you trust to help you orchestrate that? Because all those transitions you described, and all the both life cycle transitions and social transitions are really, and the variability you talked about earlier, really important. So to me, there's some kind of intermediate layer, which is like a healthcare organization, a health provider organization. And we can call it an ACO, it's not a very good term, but some kind of an entity which is taking responsibility for helping people navigate all that. And they are a middle layer of managing that complexity. And they will decide which technologies are beneficial or not, or worth the money or not, and they'll deploy them, and they'll make themselves more and more virtual and less real as an organization. Just as hospitals are beginning to become more virtual and less real, I think the whole delivery system will go that way gradually. But somebody has to manage that. I don't think as an individual person, I can probably do that very well with just my app. So I guess I am still thinking we have to solve the problem of what's the intermediate layer of healthcare organization. Maybe a Kaiser is way too big, and maybe an individual 3-doctor practice is too small. But there's something in the middle that has to take risk, be accountable for results, have enough capacity to make good decisions and bring capital together. That's how I'm seeing it. And then your job, in effect, is to hand off the right responsibility to that middle player.
I would just add one thing. As a consultant, a lot of our clients are employers with 1,000 to 5,000 employees. Typically, they'll have one carrier, whether it's Anthem, Aetna, or United. It's just that carrier. Every once in a while, they become really displeased with that carrier and change carriers, and that can be really disruptive to a member who's using services. So part of that transition is always an intensive communication campaign to the membership that things are changing. Here's what you need to do. Here's the doctor you're seeing. Are they or are they not in the new network? So I think it's incumbent on the plan sponsor to do as much reaching out to members as possible whenever their healthcare is disrupted in that way, either changing doctors or changing health plans.
Mr. Rubalcaba.
Thank you, Mr. President. Thank you for the presentation. The last discussion helped me go back to a question I had. Dr. David, you had mentioned one of the priorities should be primary care, advanced primary care, but then the Mercer presenter also talked about how the new generation may interact differently, but I'm not sure how to phrase it, but it seems to me that one thing we promote in primary care is that you want people to have engagement with their doctor, but yet their doctor doesn't advertise. It's an insurance company that advertises. The doctor, unless you're in Kaiser, the doctor does not belong to the insurance company, it belongs to a medical group. That medical group may belong to 3 different carriers, insurance carriers, so the doctor may have 6 bosses, but who knows? So I'm just curious as to if we were going to be, you challenged us to be, not be wimpy and all that kind of stuff. I'm new on this board, but my perception of CalPERS was that, they had one network, and I'm finding out we left that some years ago. Now there's many carriers, and they overlap. And so the whole thing about competition and is that a good thing or bad thing? So what would you foresee? Should there be a pilot in certain regions where there's a lot of, state is very big, and there's rural areas and urban. I think somebody said that. But there's some areas where we're fortunate to have a lot of competition. Would it make sense in those areas to just have one insurance carrier and just do some pilots and see if it works? Or, what do you guys see? If we could experiment. I think you said, Susan, the whole thing about other employers can't experiment because they're afraid about losing their workforce. And so we have, I think, some benefits. So I'm not sure if this is a question or just some brainstorming here, but how do you deal with that when you were trying to get your doctor, you were trying to get your member to engage with their primary care for the care they need, whether it's once a year or 6 times a month, and yet the billboard they see is an insurance company, and they judge quality by the billboard, not by their own personal doctor, but the doctor may have 6 insurance carriers, 1 medical group. How do you deal with that? It's just the structure that everything we deal with. I'm not sure who wants to handle that. I don't know if that's a question, so sorry. It just something you guys brought up right now. Sorry.
Yeah. Just to answer briefly, in an ideal world, CalPERS could look at each market, geographic market in California, and come up with a unique strategy for it that made sense in that market. I'm not saying that that's viable, but in an ideal world, and I'll just throw out an example, in San Diego, I think that's a market where there is very healthy competition, both among healthcare providers and healthcare payers. They're very sophisticated integrated delivery systems that are competing for patients. And we wrote a case study about how Qualcomm used that to its advantage in trying to find a provider who would be willing to create a great experience for their employees and be held accountable for both spending and quality. And they even created competition among the health insurance companies for their willingness to support Qualcomm in that relationship with the provider that they selected. So that's possible in San Diego. It may not be possible in San Francisco. So I don't know that that really answers your question, but I think there are opportunities in specific markets in California to do that sort of thing. And I don't know to what degree CalPERS can or would get into direct relationships with healthcare providers, but that certainly is the trend that I'm seeing among my most sophisticated members and what they're trying to do in key markets where they think they could get something better for their patients that way.
Let me just echo something Suzanne ended on. I think every X years, 10, 15 years, it's time to step back and look at the system as a whole and say, what's our role in it and how's it working? And I think what a lot of employers are saying to both of us now is they're not sure what the correct role for the health plan, the health insurance plan should be. A lot of these large health plans have taken on many, many roles and functions because for their own business reasons, and we've sort of enabled that because we've said, sure, we'll just write you a bigger check every year and you do more stuff. So the employers are starting to say, well, wait a minute, the management of medical care is actually not something a giant company in Minneapolis is doing well in Bakersfield and Reading. I need someone in Bakersfield and Reading to manage the medical care for people. Maybe the giant insurance company in Minnesota can do other things well. They can issue cards, they can do nurse advice lines, they can do technology and data analysis. So let's step back and rethink what we want our plan to do and what we want our doctors and hospitals to do. And how do we arrange contracts that achieve those goals, which may not be for you a direct contract that Walmart does. Maybe there's some other intermediate way of doing it. And there are a lot of new players in the market who do different kinds of administrative arrangements for these kinds of contracts. So it's just time to think about, really, you have to decide what's valuable to your members in the services they're going to get, the best services from the best source, and then how do you orchestrate that and not take the history as the only way to do it.
Hey, but thank you, David, for leading us through that thought-provoking presentation. And Ms. Del Banco, Dr. Linsky, and Mr. Scott, we're glad you could be here to share your expertise. And at this time, I think it's a time for break. Karen?
Yes, it is,
How
Henry.
about an applaud first?
Thank you. And everyone, we're going to take a quick break now. We are going to meet back here at 10:30 for our next session. Thank you.